today my topic is role of PARP inhibitor in metastatic castration-resistant prostate cancer. Next slide, please. So prostate cancer ranks 16th incidence in India. We get almost 25 to 30,000 cases per year. And the bad fact is that almost all prostate cancer patients eventually progress into metastasis, and most of them develop into a castration-resistant phase. Next slide. So there is an unmet need to improve the standard of care for the men with metastatic castration-resistant prostate cancer, because despite significant advances in the metastatic CRPC treatment, the median overall survival in the first-line setting is only 1 to 3 years. Although, next slide, please. Next. Next. So this is the flow chart of flow diagram of the natural behavior or tumor biology of a prostate cancer. At the diagnosis, there is the high PSA, and after initiation of appropriate treatment, it falls down, then slowly it increases. Then when we employ or use the first line treatment like either docetaxel or cabazitaxel or abiraterone or enzalutamide, then again it falls, then again it progresses and develops to a metastatic prostate cancer, in which the survival is hardly 1 to 3 years. So there is an increased interest in the better treatment of the metastatic CRPC patients, and that is the topic of today's discussion. Next slide, please. So what is castration-resistant prostate cancer? Means it's a progression of the disease that is either 2 or more new bone lesions or 1 soft tissue lesion as per the RECIST criteria, or the prostate cancer will involve the non-regional lymph nodes, bones, liver, lungs, or brain, and the serum testosterone level is less than 50 nanogram per 100 ml of the blood. So in this situation, as per the tumor biology, the androgen receptor pathway is often found to remain activated, and till now it remains a druggable target by using abiraterone or enzalutamide. Next slide, please. So, but it did not yield much results. So why does it happen, or what is the reason? Because metastatic prostate cancer is a biologically heterogeneous disease. In some metastatic prostate cancer, CRPC develop due to activation of the Wnt pathway, some develop due to the PI3-AKT kinase pathway, some develop due to the androgen receptor pathway, some develop due to the cell cycle aberration pathway, some develop due to the defective DNA repair pathway. So it has been seen that almost 23% mutations are present in the DNA damage repair pathway, DDR pathway. Next slide, please. So we have a car, we have a mobile, so sometimes it breaks down. So when there is a breakdown, we are able to identify the damage and we go to a showroom and get it repaired. Similarly, if there is a damage in the DNA, and why it happens? Because there are multiple genotoxic agents available and present in the body. So that causes like oxygen free radicals, stress, some radiations, all those things, they damage the DNA. And once there is a damage in the DNA, there are several mechanisms which identify the DNA damage. And based on the nature of the damage, like if there is a single strand DNA damage, then the base excision repair pathway comes into the play. If there is a bulky adduct into the DNA, then nucleotide base excision repair pathway comes into the play. If there is mismatch, then mismatch repair pathway comes, like MSH2 and MLH1. And if double-stranded break, then homologous recombination repair comes into the play. So this homologous recombination repair is a key mechanism of the repair of DNA double-stranded breaks, and right now this is the druggable target. Next slide. So this is a ray diagram. showing the DNA damage. Then once the DNA damage it is getting recognized by proper mechanism, then PARP, that is poly ADP ribose polymerase homodimerization happens, and this engages the DNA ligase 3, XRCC1 and other enzymes, repair enzymes, and they help the DNA damage to get repaired. So here this PARP enzyme inhibition, that is PARP inhibitor, comes into the play. Till now in market, this olaparib and rucaparib are available, and several other agents like niraparib are under the trial. Next slide, please. So this is a flow diagram showing the evolution of the treatment strategies of the CRPC, like enzalutamide as per the previous study, or abiraterone as per the COU study, or TAX323 proves the role of docetaxel prednisolone, or tropic study cabazitaxel, or enzalutamide AFAM study, all those things. So right now we'll discuss regarding the Triton 2 study and profound study. Next slide, please. Next slide. Mr. Rohit, next slide, please. Hello. So DNA repair gene aberrations are enriched in patients with locoregional biochemically recurrent as well as metastatic prostate cancers. The most common genes are the BRCA2 germline mutation, BRCA2 somatic mutation, BRCA1 germline mutation, then ATM germline, CHEK2, ATM, all those things. Then next slide, please. Next slide. So as far as publication in NEGM 2016, almost 10%, 11.8, almost 1 in 10% patients have germline mutations in the DNA repair gene, and 76% of the germline mutations were found in the BRCA2 region, ATM, CHEK2, and BRCA1. Next slide. So, because almost 10 to 20% patients in CRPC have some or other form of genetic mutations that hamper the DNA repair, so there is a growing consensus of testing for the BRCA gene. So, as per the different recommendations, this Philadelphia Consensus Conference supported a consideration of the BRCA2 testing, and subsequently NCCN also recommended for the BRCA gene and HRR gene testing in the CRPC, although the ESMO and European Association of Urology, they didn't support this concept. Next slide, please. So those with a positive family history of cancer should get treated, should get tested for these BRCA2 mutations. Those with a known history of DNA damage repair mutations in the family, like BRCA2, they should get themselves tested. Those with ductal or intraductal histology of prostatic adenocarcinoma should also get tested for the BRCA gene. Next. So NCCN guidelines acknowledge the prostate cancer heterogeneity, and they also recommend the BRCA gene testing. Next. So several large retrospective studies has found an association between the BRCA mutation and aggressive tumor biology, rapid progression to the metastatic disease. So I'm not going into detail of this busy slide. So the bottom line is BRCA mutation and disease aggressiveness are closely interlinked. So that gives us a thought to use other agents, newer agents other than the conventional agents targeting the androgen receptors. Next slide, please. So the PROFOUND trial, it was the first randomized phase 3 study evaluating the efficacy and safety of olaparib, that is PARP inhibitor, versus new hormonal agents in patients with homologous recombination mutated metastatic CRPC. So It was a proper phase 3 randomized study. In cohort 1, they divided the patients receiving olaparib versus physician's choice. Physician's choice means either cabazitaxel or docetaxel or enzalutamide. And in cohort B, there are other genetic mutations apart from the BRCA1, 2, and ATM. So there should be an documented evidence of metastatic CRPC qualifying HRR mutation in tumor tissue, and investigator assessed radiological progression. So the primary endpoint was radiological progression-free survival, and the secondary endpoints were time to pain progression and overall survival and safety and tolerability. Next slide. So the baseline characteristic shows that both the arms, cohort A as well as cohort A plus B, that means the olaparib arm versus physician choice, were well balanced. So there is no question of any observer bias. Next slide, please. Next slide, Rohit. Next slide. So the radiological progression-free survival benefit with olaparib was seen across pre-specified subgroups in patients with alteration of the BRCA1, BRCA2, or ATM. We can see that in this forest plot, the newer treatment modality, that is olaparib arm, was showing good response with a hazard ratio of less than 1. Next slide. So apart from the radiological progression-free survival, they also show a good objective response. So we can see that objective response in the olaparib one was almost 30% versus the physician's choice was less than 5%. Next slide. So at interim analysis, olaparib had a favorable trend in overall survival. So we can see at 6 months, the overall survival in olaparib arm was 91 versus observer physician choice was 84%. Similar trend was seen at 12 months as well as 1.5 years, that is 18 months, with a hazard ratio of 0.64. Next slide. So statistically significant as well as clinical meaningful improvement was also seen in both the cohorts. That means patients with BRCA1, BRCA2 mutated, ATM mutated versus other genes mutated. Next slide, please. So apart from the radiological progression-free survival, overall survival, there was the median time to pain progression, TTPP, was also significantly improved. Next slide. So olaparib demonstrated a statistically significant final overall survival benefit in patients with alteration of BRCA1, 2, ATM cohort, as well as the other gene mutations, cohort B also. Next slide. So the same thing, apart from the BRCA1, 2, and ATM mutation, there are CHEK2 mutation, RAD51B mutation, RAD50L mutation. All those gene mutations showed an improvement of both radiological progression, RPFS, objective response, as well as overall survival with olaparib. Next slide. So the adverse event profile for olaparib was generally consistent with the known safety profile. The most common adverse events were anemia, nausea, and fatigue. Only 4% patients developed pulmonary embolism versus 1% in the physician's choice arm. Next slide. So that shows that the olaparib is well tolerated. It's an oral tablet, well tolerated. Next slide.
Dr. Chira, please try to conclude.
So similarly, rucaparib from another manufacturer in phase 2 trial, it's based on the Triton 2. It shows a good response. Next slide.
Please try to conclude.
Yeah. Next slide. Next slide. Next. 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 Next slide. Next slide. Next. 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 So rucaparib, that also showed almost 44% improvement in the overall survival, although it is a phase 2 study. Next slide. Next. 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 There are multiple other trials are also going on. Next slide. Next. So these are the basic difference between the olaparib, that is PROFOUND study, and rucaparib, that is TRITON study. Olaparib is against the PARP 1 and PARP 2 with a ORR of only 30% versus rucaparib, it is PARP 1, PARP 2 and PARP 3 inhibitor and with an objective response rate of 50%. Next slide. Next. Next slide. Next. 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 So to conclude, almost all patients of prostate cancer will eventually progress to metastatic castration-resistant prostate cancers. Almost 10 to 20% of the CRPC patients will have some or other form of genetic mutations in the region of BRCA1, BRCA2 and ATM gene and other genes. And these are the right now the druggable targets. And we have drugs like olaparib and rucaparib, something called PARP inhibitor, which has shown to improve the radiological progression-free rate by more than 6 months, overall survival, as well as the time to progression for the pain. And these drugs are given orally with a very favorable safety profile. So to conclude, metastatic castration-resistant prostate cancer right now have a good oral drugs which improves the quality of life and overall survival. Thank you.
Thank you.